Esophageal cancer is cancer arising from the esophagus, the food pipe that runs between the throat and the stomach. Symptoms often include trouble swallowing and weight loss. Other symptoms may include pain with swallowing, a hoarse voice, enlarged lymph nodes around the clavicle, a dry cough, and possibly coughing up or vomiting blood. The two main subtypes of esophageal cancer are squamous cell cancer, which is more common in the developing world, and adenocarcinoma, which is more common in the developed world. A number of less common types also occur. The most common causes of the squamous variety are smoking tobacco, drinking alcohol, drinking very hot drinks, and a poor diet. The most common causes of the adenocarcinoma variety are smoking tobacco, obesity, and acid reflux. Squamous cell cancer arises from the skin cells that line the esophagus. Adenocarcinoma arises from glandular cells present in the lower third of the esophagus, often where they have already transformed to intestinal cell type. The disease is diagnosed by biopsy done by an endoscope. Prevention includes stopping smoking and a healthy diet. Treatment is based on the cancer's stage and location, together with the person's general condition and individual preferences. Small localized squamous cancers may be treated with surgery alone with the hope of a cure. In most other cases, chemotherapy with or without radiation therapy is used along with surgery. Larger tumors may have their growth slowed with chemotherapy and radiation therapy. In the presence of extensive disease or if the affected person is not fit enough to undergo surgery, palliative care is often recommended. Outcomes are related to the extent of the disease and other medical conditions, but generally tend to be fairly poor, as diagnosis is often late. 5-year survival rates are around 13% to 18%. As of 2012, esophageal cancer is the 8th most common cancer globally with 456,000 new cases during the year. It caused about 400,000 deaths that year, up from 345,000 in 1990. Rates vary widely between countries, with about half of all cases occurring in China. It is around 3 times more common in men than in women. Signs and symptoms. Prominent symptoms usually do not appear until the cancer has infiltrated over 60% of the tube's circumference, by which time the tumor is already in an advanced stage. Onset of symptoms is usually caused by stenosis. The first and the most common symptom is usually difficulty in swallowing, often initially experienced with solid foods and later with softer foods and liquids. Pain when swallowing is less usual initially. Weight loss is often an initial symptom in cases of the squamous cell carcinoma type, though not usually in cases of the adenocarcinoma type. Eventual weight loss due to reduced appetite and malnutrition is common. Pain behind the sternum or in the epigastric region around the stomach, often of a burning, heartburn-like nature, may be frequent and severe, worsening when food of any sort is swallowed. Another sign may be an unusually husky, raspy, or hoarse-sounding cough, a result of the tumor affecting the recurrent laryngeal nerve. The presence of the tumor may disrupt the normal contractions of the esophagus on swallowing. This can lead to nausea and vomiting, regurgitation of food, coughing, and an increased risk of aspiration pneumonia. Abnormal connections occasionally develop between the esophagus and the trachea. Early signs of this serious complication may be coughing on drinking or eating. Fistulas often lead to pneumonia, which is usually heralded by cough, fever, or aspiration. The tumor surface may be fragile and bleed, causing vomiting of blood. Compression of local structures occurs in advanced disease, leading to such problems as upper airway obstruction and superior vena cava syndrome. Symptoms of hypercalcemia may occur. If the cancer has spread elsewhere, symptoms related to metastatic disease may appear. Common sites of metastasis include nearby lymph nodes, the liver, lungs and bone. Liver metastasis can cause jaundice and ascites, while lung metastasis can cause shortness of breath, pleural effusions, etc. Causes. A number of risk factors for esophageal cancer have been identified. The two main subtypes have different risk factors, but both types are more common in men, and are most common in the over 60s. Tobacco and alcohol are the greatest risk factors for esophageal squamous cell carcinoma, especially in combination. Some data suggest that about half of squamous cell carcinoma cases are due to tobacco and about 1/3 to alcohol, while over 3/4 of the cases in men are due to the combination of smoking and heavy drinking. Gastroesophageal reflux disease and its resultant Barrett's esophagus increase the risk of esophageal adenocarcinoma, due to chronic irritation of the mucosal lining by stomach acids and bile acids. Obesity increases the risk of adenocarcinoma fourfold. It is suspected that increased risk of reflux may be behind this association. Age: most patients are over 60, and the median in U.S. patients is 67. Tobacco smoking and heavy alcohol use increase the risk, and together appear to increase the risk more than either individually. Tobacco smoking is also linked to esophageal adenocarcinoma, though no scientific evidence has been found between it and alcohol. Human papillomavirus, corrosive injury to the esophagus by swallowing strong alkalines or acids, particular dietary substances, such as nitrosamines. A medical history of other head and neck cancers increases the chance of developing a second cancer in the head and neck area, including esophageal cancer. Plummer-Vinson syndrome, tylosis and Howell-Evans syndrome, radiation therapy for other conditions in the mediastinum, celiac disease predisposes towards squamous cell carcinoma. Thermal injury as a result of drinking hot beverages or eating hot food, alcohol consumption in individuals predisposed to alcohol flush reaction, achalasia, the role of Helicobacter pylori and progression to esophageal adenocarcinoma is still uncertain, but, on the basis of population data, it may carry a protective effect. It is postulated that H. pylori induces chronic gastritis, which is a risk factor for reflux, which in turn is a risk factor for esophageal adenocarcinoma. Diagnosis. Clinical evaluation: although an occlusive tumor may be suspected on a barium swallow or barium meal, the diagnosis is best made with esophagogastroduodenoscopy. This involves the passing of a flexible tube down the esophagus and examining the wall. Biopsies taken of suspicious lesions are then examined histologically for signs of malignancy. Additional testing is usually performed to estimate the tumor stage. Computed tomography of the chest, abdomen and pelvis can evaluate whether the cancer has spread to adjacent tissues or distant organs. The sensitivity of a CT scan is limited by its ability to detect masses generally larger than 1 cm. Positron emission tomography is also used to estimate the extent of the disease and is regarded as more precise than CT alone. Esophageal endoscopic ultrasound can provide staging information regarding the level of tumor invasion, and possible spread to regional lymph nodes. The location of the tumor is generally measured by the distance from the teeth. The esophagus is commonly divided into 3 parts for purposes of determining the location. Adenocarcinomas tend to occur distally and squamous cell carcinomas proximally, but the converse may also be the case. Classification. Esophageal cancers are typically carcinomas which arise from the epithelium, or surface lining, of the esophagus. Most esophageal cancers fall into one of 2 classes: squamous cell carcinomas, which are similar to head and neck cancer in their appearance and association with tobacco and alcohol consumption, and adenocarcinomas, which are often associated with a history of GERD and Barrett's esophagus. A general rule of thumb is that a cancer in the upper 2/3 is a squamous cell carcinoma and one in the lower 1/3 is an adenocarcinoma. Rare histologic types of esophageal cancer are different variants of the squamous cell carcinoma, and non-epithelial tumors, such as leiomyosarcoma, malignant melanoma, rhabdomyosarcoma, lymphoma, and others. Prevention. Prevention includes stopping smoking. Risk appears to be less in people using aspirin or related NSAIDs, but this is not conclusive. According to the National Cancer Institute, diets high in cruciferous and green and yellow vegetables and fruits are associated with a decreased risk of esophageal cancer. Moderate coffee consumption is associated with a decreased risk. Screening. People with Barrett esophagus are at much higher risk, and should undergo regular endoscopic screening for the early signs of cancer. Because the benefit of screening for adenocarcinoma in people without symptoms is unclear, it is not recommended in the United States. Some areas of the world with high rates of squamous carcinoma have screening programs. Management. The treatment is determined by the cellular type of cancer, the stage of the disease, the general condition of the patient, and other diseases present. On the whole, adequate nutrition needs to be assured, and adequate dental care is vital. If the person cannot swallow at all, an esophageal stent may be inserted to keep the esophagus open. Stents may also assist in occluding fistulas. A nasogastric tube may be necessary to continue feeding while treatment for the tumor is given, and some patients require a gastrostomy. The latter two are especially important if the patient tends to aspirate food or saliva into the airways, predisposing for aspiration pneumonia. Esophagectomy is the removal of a segment of the esophagus. As this shortens the length of the remaining esophagus, some other segment of the digestive tract is pulled up to the chest cavity and interposed. If the tumor is not resectable or the patient is not fit for surgery, palliative esophageal stenting can allow the patient to tolerate a soft diet. Types of esophagectomy. The thoraco-abdominal approach opens the abdominal and thoracic cavities together. The two-stage Ivor-Lewis approach involves an initial laparotomy and construction of a gastric tube, followed by a right thoracotomy to excise the tumor and create an esophagogastric anastomosis. The three-stage McKeown approach adds a third incision in the neck to complete the cervical anastomosis. Data are accumulating to indicate endoscopic therapy is a safe, less invasive, and effective therapy for very early esophageal cancer. The candidates for endoscopic therapy are stage 1 patients with tumors invading into the lamina propria or submucosa who do not have regional or distant metastasis. Patients with carcinoma in situ or high-grade dysplasia can also be treated with endoscopic therapy. Submucosal cancers with increased risk of nodal metastasis may not be as amenable to curative therapy. Endoscopic resection. Forms of endoscopic therapy have been used for stage 0 and I disease, endoscopic mucosal resection and mucosal ablation using radiofrequency ablation, photodynamic therapy, and EYG laser, or argon plasma coagulation. IM has been advocated for early cancers and has been shown to be a less invasive, safe, and highly effective non-surgical therapy for early squamous cell esophageal cancer. It has also been shown to be safe and effective for early adenocarcinoma arising in Barrett, a Euro unregistered trademark esophagus. The prognosis after treatment with IMA is comparable to surgical resection. This technique can be attempted in patients, without evidence of nodal or distant metastases, with differentiated tumors that are slightly raised and less than 2 cm in diameter, or in differentiated tumors that are ulcerated and less than 1 cm in diameter. The most commonly employed modalities of IMA include strip biopsy, double snare polypectomy, resection with combined use of highly concentrated saline and epinephrine, and resection using a cap. The strip biopsy method for endoscopic mucosal resection of esophageal cancer is performed with a double-channel endoscope equipped with grasp and forceps and snare. After marking the lesion border with an electric coagulator, saline is injected into the submucosa below the lesion to separate the lesion from the muscle layer and to force its protrusion. The grasp and forceps are passed through the snare loop. The mucosa surrounding the lesion is grasped, lifted, and strangulated and resected by electrocautery. The endoscopic double snare polypectomy method is indicated for protruding lesions. Using a double-channel scope, the lesion is grasped and lifted by the first snare and strangulated with the second snare for complete resection. Endoscopic resection with injection of concentrated saline and epinephrine is carried out using a double-channel scope. The lesion borders are marked with a coagulator. Highly concentrated saline and epinephrine are injected into the submucosal layer to swell the area containing the lesion and elucidate the markings. The mucosa outside the demarcated border is excised using a high-frequency scalpel to the depth of the submucosal layer. The resected mucosa is lifted and grasped with forceps, trapping and strangulating the lesion with a snare, and then resected by electrocautery. Another method of EMR employs the use of a clear cap and pre-looped snare inside the cap. After insertion, the cap is placed on the lesion and the mucosa containing the lesion is drawn up inside the cap by aspiration. The mucosa is caught by the snare and strangulated, and finally resected by electrocautery. This is called the band and snare, or suck and cut technique. The resected specimen is retrieved and submitted for microscopic examination for determination of tumor invasion depth, resection margin, and possible vascular involvement. The resulting ulcer heals within 3 weeks. EMR can also be used to debulk or completely treat polypoid dysplastic or malignant lesions in Barrett, a Euro unregistered trademark esophagus, the known precursor lesion to esophageal adenocarcinoma. In a preliminary report from Germany, EMR was performed as primary treatment or adjunctive therapy following photodynamic therapy for early adenocarcinomas in Barrett's esophagus. The suck and cut technique was used, as well as the band and cut technique. Although all tumors were resected without difficulty, 12.5% developed bleeding. 81% of the lesions were completely resected. The other lesions were also treated with other endoscopic techniques. The major complications of endoscopic mucosal resection include postoperative bleeding, perforation, and stricture formation. During the procedure, an injection of 100,000 times diluted epinephrine into the muscular wall, along with high-frequency coagulation or clipping, can be applied to the bleeding point for hemostasis. It is important to administer acid-reducing medications to prevent postoperative hemorrhage. Perforation may be prevented with sufficient saline injection to raise the mucosa containing the lesion. The non-lifting sign, and complaints of pain when the snare strangulates the lesion are contraindications of EMR. When perforation is recognized immediately after a procedure, the perforation should be closed by clips. Surgery should be considered in cases of endoscopic closure failure. The incidence of complications ranges from 0–50% and squamous cell recurrence rates range from 0–8%. Other approaches. Laser therapy is the use of high-intensity light to destroy tumor cells. It affects only the treated area. This is typically done if the cancer cannot be removed by surgery. The relief of a blockage can help to reduce dysphagia and pain. Photodynamic therapy, a type of laser therapy, involves the use of drugs that are absorbed by cancer cells. When exposed to a special light, the drugs become active and destroy the cancer cells. Chemotherapy depends on the tumor type, but tends to be cisplatin-based every 3 weeks with fluorouracil either continuously or every 3 weeks. In more recent studies, addition of epirubicin was better than other comparable regimens in advanced non-resectable cancer. Chemotherapy may be given after surgery, before surgery or if surgery is not possible. In this case, cisplatin and 5-FU are used. Ongoing trials compare various combinations of chemotherapy. The Phase 2-3 Real-2 trial for example compares 4 regimens containing epirubicin and either cisplatin or oxaliplatin, and either continuously infused fluorouracil or capecitabine. Radiotherapy is given before, during, or after chemotherapy or surgery, and sometimes on its own to control symptoms. In patients with localized disease but contraindications to surgery, radical radiotherapy may be used with curative intent. Radiofrequency ablation is a new treatment modality for the treatment of Barrett's esophagus and dysplasia, and has been the subject of numerous published clinical trials. The findings demonstrate radiofrequency ablation has an efficacy of 80–90% or greater with respect to complete clearance of Barrett's esophagus and dysplasia with durability up to 5 years and a favorable safety profile. Recent clinical trials have shown that endoscopic resection of esophageal mucosal irregularities and nodules which contain dysplasia or carcinoma combined with subsequent radiofrequency ablation of the remaining flat Barrett's esophagus and dysplasia can effectively and safely eradicate the disease. Further, a recent multicenter randomized controlled trial found that in patients with Barrett's esophagus containing nodules or mucosal irregularities which contained high-grade dysplasia or cancer, Subsequent radiofrequency ablation resulted not only in eradication of Barrett's esophagus and dysplasia, but also had significantly less esophageal stricture versus patients who had circumferential endoscopic mucosal resection for their disease. Follow-up: patients are followed up frequently after a treatment regimen has been completed. Frequently, other treatments are necessary to improve symptoms and maximize nutrition. Prognosis: in general, the prognosis of esophageal cancer is quite poor, because most patients present with advanced disease. By the time the first symptoms such as dysphagia start manifesting themselves, the cancer has already well progressed. The overall 5-year survival rate in the United States is around 15%, with most people dying within the first year of diagnosis. Individualized prognosis depends largely on stage. Those with cancer restricted entirely to the esophageal mucosa have about an 80% 5YSR, but submucosal involvement brings this down to less than 50%. Extension into the muscularis propria has meant a 20% 5YSR, and extension to the structures adjacent to the esophagus results in a 7% 5YSR. Patients with distant metastases have a less than 3% 5YSR. Epidemiology. Esophageal cancer is the 8th most frequent cancer diagnosis worldwide, and because of its poor prognosis it is the 6th most common cause of cancer-related death. It caused about 395,000 deaths in 2010, up from 345,000 in 1990. Its incidence varies greatly among different geographical areas, as does the relative preponderance of the two main histological types. The cancer is particularly frequent in the so-called Asian esophageal cancer belt, an area that passes through northern China, southern Russia, northeastern Iran, northern Afghanistan and eastern Turkey. In sub-Saharan Africa, where the problem has long been recognized, incidence is much higher in countries in the eastern and southern parts of the region. Squamous cell carcinoma is the most common type of esophageal cancer worldwide, comprising 60 to 70% of all cases, while adenocarcinomas account for a further 20 to 30%. In the Asian esophageal cancer belt that stretches from northeast China to the Middle East, incidence rates of the squamous cell variety have been reported to be as high as 100 new cases per 100,000 person-years. In some developed countries, including Australia, Finland, France, the United States and the United Kingdom, adenocarcinoma is the most common form. Incidence of adenocarcinoma has increased in Western countries. In the United States, esophageal cancer is the 7th leading cause of cancer death among males. The National Cancer Institute estimated there were about 18,000 new cases and more than 15,000 deaths from esophageal cancer in 2013. The squamous cell type is more common among African American males with a history of heavy smoking or alcohol use. Until the 1970s, squamous cell carcinoma made up the vast majority of esophageal cancers in the United States. In recent decades, incidence of adenocarcinoma of the esophagus steadily rose in the United States to the point that it has now surpassed squamous cell carcinoma. In contrast to squamous cell carcinoma, esophageal adenocarcinoma is more common in Caucasian men than it is in African Americans. Multiple reports indicate esophageal adenocarcinoma incidence has increased during the past 20 years, especially in non-Hispanic white men. Esophageal adenocarcinoma age-adjusted incidence increased in New Mexico from 1973 to 1997. This increase was found in non-Hispanic whites and Hispanics and became predominant in non-Hispanic whites. Esophageal cancer incidence and mortality rates for African Americans continue to be higher than the rate for Caucasians. However, incidence and mortality of esophageal cancer has significantly decreased among African Americans since the early 1980s, whereas with Caucasians, it has slightly increased. Between 1975 and 2004, incidence of the adenocarcinoma type increased among white American males by over 460% and among white American females by 335%. References. External links: NCI Esophageal Cancer, Cancer.net, Esophageal Cancer from Cancer Management, a Multidisciplinary Approach, Learn more about esophageal cancer through esophageal cancer at Cancer Research UK.